Is it visible to everyone?
Doctor, you're live now on YouTube. You can
Okay,
get started.
thank you so much, sir. Hello. Hello.
Hello, sir. Good afternoon, sir.
Good
So,
afternoon.
Doctor, you're the host now again. So I'm going to
Okay.
log out.
Okay, sure.
And
Sure.
I'll have the YouTube on. Yeah. All right.
Okay,
Thanks.
fine. Thank you so much. Thank you. Welcome everyone for the class. Let me first introduce myself. I am Dr. Amandeep Singh Sasdeva. I am working as a specialty doctor in Queen Elizabeth, the Queen Mother Hospital, Margate, UK. I worked in India nearly 15 years as a consultant. Then I moved here to the UK last year after clearing my EDAIC. And now I am working as a specialty doctor here. So we are going to start. We have got with us one volunteer who has kindly consented to be taking part in the Viva, Dr. Indumani Karthik. And we had another volunteer who just dropped out because he had got some emergency work, emergency duty came in. So what we will do is we will start. I have some few slides just to make you aware of the hypothyroid patients and all those things. I will not go into much details because you know most of the things. And then we will take on the Viva and then what the questions you can be asked on this topic. Is it okay?
Okay.
Is everybody seeing my screen?
Yes, sir.
Okay, so let's start with the anesthesia for hyperthyroid patient. First of all, like this, what is thyroid? Thyroid gland. It is an endocrine gland in the anterior and lateral parts of the aspects of the neck. Now, it's bilobed, connected by isthmus. Upper border of the isthmus is below the cricoid cartilage, weighs about 20 grams. And the most important thing, the nerves in association with the thyroid gland. Recurrent laryngeal nerve and external laryngeal nerve, they are in close relation to the gland. Why they are so important? Because because with the hypothyroidism or the thyroid gland, thyroid patient, thyroid case, you can get two different types of the cases. You can get a case scenario where you will have to get a question in which you have to give anesthesia for a patient for thyroidectomy, either for a thyroid optic nodule or CA thyroid or goiter, or you have to go give an anesthesia for a patient with hypothyroidism or hyperthyroidism for a non-thyroid surgery. Just like you have to get a cesarean done, you have to get some other non-thyroid surgery done. So we have to prepare for both of things. If you are doing a surgery for thyroid gland itself, for the goiter, then these recurrent laryngeal nerve and external laryngeal comes into the picture. We will go into this a little bit later on. Okay. Now the next is just hold on. It's not coming. Okay. So these are the vertebral levels. You can see where the thyroid hyoid bone is there. It's connected with thyroid hyoid cartilage, cricoid cartilage, first tracheal ring, second to fourth tracheal ring. The thyroid isthmus is there. It's pressing on centrally on the trachea. Vertebral level C5 to T1, and these are the main basic things about thyroid. Now its innervation. It is innervated by both the adrenergic and the cholinergic nervous system. The gland is made up of follicles with proteinaceous colloid called colloid. Colloid as thyroglobulin. It is an iodinated glycoprotein substance which is used for thyroid hormone synthesis. Now, thyroid hormone synthesis, we need to know the process of the thyroid hormone synthesis. I'm not going to the details of that because it's very rarely that you will be asked in a clinical case scenario about how the thyroid hormone is synthesized. It will be asked you in the first Viva, the pharmacophysiology. It may be asked there. Okay. It also bears a parafollicular cells for calcitonin, and most importantly, how the thyroid hormone secretion is controlled. Hypothalamic HPA axis plays an important role in the thyroid metabolism. How it does it? Thyroid gland secretes T3 and T4, which are controlled by the pituitary, by the TSH, which is controlled by the hypothalamus by TRH. Okay, these are and everybody exerts a negative feedback loop system over the another. Okay. So coming on to blood supply to the thyroid gland, why it is more important? Because thyroid has got two different types of blood supply: superior thyroid artery and inferior thyroid artery. Superior thyroid artery is a branch of external carotid artery, as you can see, and the inferior thyroid artery is a branch of thyrocervical trunk. And the another thyroid supply is thyroidema artery. Now, Why it is important? Because when you have to take out the thyroid gland for the thyroid surgery, you have to be aware of not damaging the nerves at that time. Just feel that here is a superior pole, lateral pole, and lower pole. And this is the recurrent laryngeal nerve, which is a very close relation to the inferior thyroid artery from the thyrocervical trunk. And superior thyroid artery is from the external carotid artery, which is not in a close relation to any of the nerves. So while we are dissecting the artery and uh, taking care of the blood supply, it is very common to get the recurrent laryngeal nerve damage. Now, coming on to this is about the relationship anatomy. It's in just a nutshell. I'm not going into much of the details because our question is on the its anesthetic implications. As I told you, what is HPX is? Everybody knows hypothalamus releases thyrotropin releasing hormone, which instructs the anterior pituitary gland to secrete thyroid stimulating hormones, which further causes the thyroid glands to increase the T3 and the T4 hormones. T4 is thyroxine and T is triiodothyronine. The main actions are increased metabolism, growth and development, and increased catecholamine effect. So everybody, the thyroid hormones exert a negative feedback effect on the anterior pituitary gland, which exerts a negative feedback on the hypothalamus itself. Now coming on to the hypothyroidism. It is very relatively common in the adult population, can be of the two types, primary hypothyroidism and the secondary hypothyroidism. What is primary hypothyroidism? When the disease itself is in the thyroid gland, okay, either due to any thyroiditis, Hashimoto's thyroiditis, any TPO antibodies. Secondary hypothyroidism is when the disease is above the thyroid gland, that's in the pituitary or in the hypothalamus. Now, coming on to this is like primary hypothyroidism, disease of thyroid. Secondary hypothyroidism, diseases of the pituitary, pituitary makes TSH, and tertiary hypothyroidism is disease of the hypothalamus. Now, primary hypothyroidism, why it's called primary hypothyroidism? Because there's a decreased production of the thyroid hormones in spite of adequate or increased levels of the TSH. And the TRH administration causes exaggerated TSH elevation. Secondary hypothyroidism is because there are reduced levels of the T3 and T4, and there's reduced TSH levels. TRH stimulation confirms that the origin of the thyroid disease is the pituitary because it shows absent or the blunted reflex response to the TRH stimulation. Now, coming on to the major causes of hypothyroidism, why does hypothyroidism is caused? First, major cause is iodine deficiency in diet. There are areas in the world where the main water is deficient in the iodine. Most of the areas are in India also and other parts of the world also. So there, iodine deficiency in the diet is the most common cause of the hypothyroidism. Secondly, there is inflammatory processes of the tissue of the thyroid gland. Then complete or partial removal of the thyroid gland due to anything, either it may be there is a thyroid tumor or there was some goiter. Unfavorable environmental factors, someone is working in the radiation sector, radioactive radiation, that causes the thyroid gland to get atrophied. Anomalies in the intrauterine development of the organs of the endocrine system. Finally, the use of radioactive iodine for therapeutic purposes. And most commonly, that is, and one of the most important thing, that is drug therapy, depressing the thyroid function. If we will come on to that, the drugs which are most commonly encountered in causing the hypothyroid and which every anesthetist should be aware of are 2 or 3 major drugs. One is amiodarone, the other is lithium. These are the 2 major drugs that the most of the anesthetic patients, if they are coming in the hypothyroid state, you should always take history of their intake to any reason. Now, thyroid disorders. Causes of hypothyroidism, primary, secondary, and tertiary. Tertiary is hypothalamic dysfunction. Secondary is hypopituitary adenoma, ablative therapy, pituitary destruction. Primary, I've told you, iodine deficiency, excess iodine intake, thyroid ablation, Hashimoto's thyroiditis, coitogenic foods like cabbage, and lithium iodide antithyroid drugs. Now, when we go to examine a patient, with the patient having any hypothyroidism, we should know what are the symptoms of the hypothyroidism so that we can know what to see in hypothyroidism patients, what to examine. The first thing is patient may be having some thinning of hair loss, loss of arthralgia, cardiac failure, cardiomegaly, carpal tunnel syndrome, constipation, decreased sweating, Deep hoarse voice. What you will see the patient, when you touch the patient, when you feel the pulse, patient will be most likely bradycardic. Patient will have dry skin. Deep hoarse voice. You must ask the patient whether he feels cold, inexplicably more cold than the weather itself. Lethargy. Females may have menorrhagia. Patient may have non-pitting edema over the tibia and pleural and pericardial effusions, periorbital edema. These are some of the features that you may, when you give to see, do a pre-operative evaluation of the patient, you should keep in mind that these patients we have to ask. This patient may have sleep apnea, slow gastric emptying time, slow mental functions, movement, weight gain. When you open the patient, ask the patient to open your mouth for the airway assessment, then at that time you can see patient has a coarse facial features and a large tongue. Any large tongue disproportionate to the tongue size in the face size should prompt you with a high index of suspicion that patient may have got hypothyroidism. Now, how to diagnose the because once we have diagnosed the patient, that patient has got a hypothyroidism, we order a thyroid function test, and the patient comes up with the report what to do now. Now, there are two things in a patient with hypothyroidism. Either the patient will have a normal TSH or the patient will have high TSH. If the patient is having high TSH and the low free T4, then the patient is diagnosed to have primary hypothyroidism. But if the patient has got normal T4 and high TSH, the patient has got subclinical hypothyroidism. In those cases, you still need to start the patient on the thyroxine medication and wait for patient to be turned as euthyroid. Now the patient has got normal TSH. The other arm is the normal TSH. Patient has got low T4. That may be secondary hypothyroidism, either the pituitary or the hypothyroidism, or is a severe non-thyroid illness, like that is euthyroid 6 syndrome. That is a different thing that you most likely don't encounter in day-to-day practice. Now coming upon to hypothyroid and anesthesia. Mild to moderate thyroid function has minimal impacts perioperatively. The features expressed in hypothyroid state directs the precautions to be taken perioperatively and intraoperatively. Hypothyroidism reduces the anesthetic requirement slightly, but the treatment and the determination of the medical treatment and documentation of the euthyroid state before you take up the patient for any elective surgery is must. Now, mild to moderate thyroid function impacts the patient perioperatively. It reduces anesthetic requirement slightly, especially of the muscle relaxants. Any patient who has got muscle hypothyroidism, uncontrolled hypothyroidism, the muscle relaxants will have an exaggerated effect as the patient already is in the hypotonic or hypomyotonia state. So the muscle relaxant, the same dose of muscle relaxants will cause more prolonged duration of the muscle relaxation in the hypothyroid patients due to two reasons. One, their metabolism is decreased. Secondly, patient is already hypotonic. Third, hypothyroid patients are more common, more predisposed to hypothermia. So, and if the patient's hypothermic temperature is not taken care of during the surgery, during the long surgeries, you may end up in a prolonged state of muscle relaxation when you feel that you have given the same amount of the muscle relaxants as normally. Now, coming on to, let's divide the pre-operative, intraoperative, and perioperative period. First of all, the pre-operative period, euthyroid state is ideal for the surgical elective patients. If it's an emergency, you have to do it. You have to do the surgery by taking consent, proper consent, explaining the patient. These are the risks due to the hypothyroid situation, whether you want to go ahead or not, and what are the complications, risks, and the need involved in doing the surgery at this stage in this hypothyroid state. For chronic thyroid disorder, a preoperative thyroid function is needed, and the reliable report is which is less than 6 months. But it's not like that less than 6 months is the mandatory period. If the patient is not taking any medication in the last 6 months, then you should get a fresh report done. Suppose the patient has got a fresh report done, that TSH is normal, patient stopped taking the thyroid medication, and still when you examine the patient, you feel patient is feeling too much cold while it's hot outside, patient heart rate is low, patient is showing signs and symptoms of hypothyroidism. Always take care of the patient's clinical station rather than a report. Now, thyroid stimulating hormone TSH is the best to evaluate the hypothyroidism. Surgical stress may precipitate a mixed edema or thyroid stroma in untreated or severe cases. Thyroid stroma in patients where the patient is already having hypothyroid, and the mixed edema where the patient is already hypothyroid. Now, coming on what I told you already, elective surgeries must be postponed until the patient is euthyroid. Emergency surgery must be done after consultation with the endocrinologist. Now, coming on to this thing with the consultation with the endocrinologist, many a times we see the endocrinologist gives the fitness, the patient is fit for the surgery. But as an anesthetist, I always feel we should never ask any branch for fitness of the surgery. We should ask whether the patient needs any pre-optimization before the surgery. If yes, please prescribe the drugs for the optimization of the surgery. Fitness is to be decided always by the anesthetist. Even if the endocrinologist says that the patient is fit for anesthesia, at the end of the day, you are the anesthetist in charge of the patient, and you have to take into your own clinical sense and judgment whether you can go ahead with the patient safely, whether you can give anesthesia safely and bring the patient, awaken the patient safely, because endocrinologist or anybody else is not going to come at that stage of the time. Now, if the patient is for the thyroid surgery, you may need to get a chest X-ray or CT scan to rule out the tracheal or the mediastinal involvement if the patient is having retrosternal goiter involvement. Most important thing, always continue the drug thyroxine on the day of surgery. Never forget to do that. Now, intraoperative period. There is always increased risk when the hypothyroid patient goes to the general or regional anesthesia. General anesthesia, increased sensitivity to sedatives, increased sensitivity to muscle relaxants, increased sensitivity to general anesthetics. So you should always titrate the dose accordingly. Always prefer regional anesthesia wherever it can be done so that you are not landing up into a prolonged phase of muscle relaxation. And when giving regional anesthesia, consider and titrate the dose of the sedatives that you give, like TCI or any other drugs, so the patient doesn't go into the hypoventilation, because these patients can go into the hypoventilation, can accumulate the carbon dioxide, and again going into that vicious cycle. Now, airways, like difficult intubation, patient may have swollen oral cavity, edematous vocal cords, goitrous enlargement, large tongue. These all are risk factors for difficult intubation. Aspiration rings. Difficult intubation is one thing more. When the patient is going for thyroid surgery, retrosternal goiter, you should always feel whether you can intubate this patient awake for fiber optic intubation or for the inhalation anesthetics. Because the thing with the fiber optic intubation is if you're putting the fiber optic intubation, sedating the patient, whether you are sure that it will not collapse the airway, it will not obstruct the airway completely. Thirdly, aspiration risk and regurgitation, because there's a decreased gastric emptying time, so it's always there. Now, cardiovascular changes. Patient is having hypodynamic circulation, low blood pressure, decreased cardiac output, decreased stroke volume, decreased heart rate, decreased baroreceptor reflexes. Respiratory changes, enhanced suppression of ventilatory response to hypoxia and hypercarbia. Hematological abnormalities. Anemia in 25 to 50% of the patients, platelet dysfunction and coagulation factor. Always consider this, always get a coagulation factor and platelets done before any regional anesthesia is attempted. Electrolyte imbalances, hyponatremia is the most common. Metabolic demands, hypoglycemia is common. Hypothermia is quicker onset, so it's always better to warm the patient for the long surgeries and the decreased neuromuscular excitability. Now, precautions. Extremely sensitive to narcotics and sedatives. Again, hypothyroidism affects minimally on the minimal MAC of the inhalation anesthetics. Due to decreased hepatic metabolism and renal excretion of the drugs, induction agents and neuromuscular blockers must be used with cautions. Now, these are the basic small things that I needed to tell you. Now, let's call Dr. Indumati. Indumati, can you hear me?
Yes,
I'm just going with the same question that you can find out in your podcast. We will try to divert from this here. You are asked to assess a 67-year-old woman for a subtotal thyroidectomy. Describe your pre-operative assessment. Let me start it. When you are asked like this, pre-operative assessment, first of all, you should start your answer, history, physical examination, laboratory investigations, and you should tell why you are asking this question in the history.
Okay, sir.
Then physical and laboratory investigations. And then you should pre-operative investigations. At the end of the day, you should summarize that this is a 67-year-old female with so-and-so comorbidities. This is an airway. This is a pre-operative assessment. That's why I want to go ahead with this. This is my plan. Okay, you can start now. Thank you.
Okay, sir. Thank you, sir.
Okay, well.
So to begin with, I will go with the detailed history, examination, and investigations for this patient, focusing more on the current thyroid status of the patient and any signs and symptoms of airway compromise. So when coming to history, after the general history, with specific to thyroid hypothyroidism, I will ask the patient for any history of any lethargy, excessive tiredness, any history of weight gain, cold intolerance, and decreased sweating, and also a general mental slowing of the patient, and any history of muscle cramps and aches.
Okay.
Then coming to the airway, asking history of regarding airway compromise, I will ask for any changes in the voice, any dysphagia which is present, any stridor, and while lying flat, whether the dyspnea and the stridor increases for the patient. With
Okay.
this, and whether there is the cough which is poor in quality, and any history of aspiration also.
Okay.
And
Why would you ask the history of whether the patient is having increased shortness of breath while lying down? What do you suspect?
Sir, a compression of the trachea by the mass with a large mass can cause compression of the trachea, and also even a retrosternal extension of the mass also can cause compression, sir.
Okay,
So,
fine. Thank you. Next, continue.
So after this history, after the detailed history regarding the thyroid and the airway compromise, I will also ask about past history, the medication history, and any previous anesthesia and any histories regarding that, and also regarding the allergies. I will then move on to the examination, focusing on the thyroid and mostly on the airway examination, sir.
Okay.
So when it comes to the thyroid, I will check for the size. I will ask for the onset, the duration, and the progression, and also for the size of the thyroid. And next, I will also check for the for airway. When it comes to the airway, I will check for mouth opening and the large tongue, Malampati grading, and I will also look for any tracheal deviation which might be present there because of the mass.
Okay, good.
And after
What
this,
else in physical examination?
physical examination, I will also look for, sir, specific to the thyroid or general, sir?
You have to not specific the thyroid. You have to do physical examination. As I have asked you the pre-operative assessment, you have to see about everything of the patient.
Yeah, so for general features, I will look for a dry skin, dry coarse hair, and decreased sweating. Then I will see for any clubbing of the nails, and in that is the general. And for non-pitting pedal edema also, sir, I will look for that because hypothyroid patients have that. Coming to the CVS, I will look for the heart rate. Mostly the patients will be bradycardic, and they will have a hypodynamic circulation, and so that one, sir. And then for respiratory wise, I will check the respiratory rate and at the air entry. Sometimes hypothyroid patients will have a pleural effusion, so I will rule out that also. And
okay,
yeah,
very good. Now, what are the investigations that you would like to get this patient done?
Yeah, so
before you take the patient for surgery.
So I will like to divide it into blood investigations and the other investigations. In blood investigations, I would like to do thyroid profile beginning, look for TSH, free T3 and T4, and then I would do a complete blood count. In that, I would like to concentrate on the HB because most of the hypothyroid patients are anemic, and the platelet because of they have thrombocytopenia and platelet dysfunction as well. And then I will also like to do urea creatinine in case the patient is elderly. I would also look for the electrolytes, especially sodium, because most of them are hyponatremic. And I would like to take a baseline of the calcium values also, sir.
Okay, fine. Thank you. Good.
So I will also do the blood grouping and typing, sir, beforehand itself. And the other investigations, can I proceed, sir, with the other investigations?
Yeah, please.
So I would like to do an ECG, and in the ECG, I would see mainly for bradycardia and conduction defects in the patient. And I would also like to take a chest X-ray, AP view, just to rule out because of dyspnea, to rule out any other causes, and to also say for pleural effusion, sir. And I would like to take X-ray of the neck, AP and lateral view, to see for the deviation of the trachea and any compression. And the
Okay.
CT neck, in case there is a compression and deviation, I would, and if the patient's history suggests so, I would go ahead with taking a CT neck in order to identify the site and the extent of the compression.
Okay, very good.
In case if I may need, it's a large goiter, I may need an emergency tracheostomy. So I would also like to do an ultrasound to check for any major vessels, any vessels or large vessels which are nearby. And I would also do a nasoendoscopy to check the status of the larynx and the movement of the vocal cords. And
Very good.
generally, since if it's a large goiter and I would proceed with the fiber optic intubation, that will give me an idea beforehand. And
Okay.
in case there is severe obstruction, I would go with flow volume loops to see the site of obstruction and the extent of it also.
Okay, very well summarized.
Okay.
Very well summarized. Thank you so much about the investigations and the pre-operative assessment. We have covered most of the things.
Yes, sir.
If there is a pre-operative nasoendoscopy is not visible, we can ask our ENT colleagues to get an indirect laryngoscopy done and to at least that's a minimum investigation for a thyroid surgery, indirect laryngoscopy, just to know how the vocal cords are moving, whether
Yes.
whether there is any paralysis beforehand or not. Because
Okay.
this is important for two reasons. One, that you will get to know that your intubation hasn't damaged the vocal cords. It will
Yeah.
make you safe medically legally that vocal cord was in this shape, in this state before
Yes.
you give the anesthesia.
Okay,
And
sir.
secondly, you will know the vocal cord function prior to the surgery, whether there was any paralysis. It's just to be safe on the both fronts. It will
Okay.
help you in making your plan for the intubation, whether you want to go to the fiber optic intubation a week, or whether you want to go to the inhalation anesthetics, or whether you feel that you can intubate the patient with the normal propofol induction. And
Okay.
secondly, is that I told you is medical legally. You should get these things documented in properly. Okay.
Yes, sir.
Now, this lady, after the investigations Dr. Indumani has done, this patient has come with a large goiter with evidence of retrosternal extension. She is uncomfortably short of breath when she is lying down flat.
Yes, sir.
Clinically and biochemically, she is euthyroid.
Okay, sir.
A CT scan of her thorax shows a marked deviation and narrowing of the trachea at the level of upper sternum. Now, what are your options for the technique of induction of anesthesia in this patient? And how will you proceed? Thank you.
Okay, sir. Thank you, sir. So, pre-operatively, I will, that is, I would like to split my answer into pre-operative, intraoperative, and post-operative, sir. So, in the pre-operative period, I will see the patient the night before the surgery. I will get an informed and written consent from the patient. I would also like to get a high-risk consent for post-operative ventilation and ICU care.
Okay.
And I would also inquire the ICU regarding the availability of the bed, and I will reserve one.
Okay.
On the night of the surgery, I will keep the patient NPO from midnight, and
Okay.
I will avoid any sedative medications. And since the patient's hypothyroid patient, since this patient is euthyroid, but I would like to start an IV maintenance just to make sure the plasma volume is not depleted just before the surgery.
Okay.
And I would advise the patient to take the thyroid medications on the morning of surgery. And I would
Okay.
cross-match and reserve blood, sir, because I anticipate excessive bleeding in this patient since it also has retrosternal extension.
Okay.
And then I will make sure my OT is prepared. I will make sure there's a good working suction, 2 suctions. In fact, auxiliary oxygen the cylinder is there. I will get ready with a difficult airway cart and also all the drugs labeled. And I will check for the machine, the anesthetic voice machine. I would make sure a fluid warmer and a bear hugger are available. And I will also make sure the neuromuscular monitoring device is also available, sir. And I will
Okay.
also keep the emergency.
Okay, everything is available. You have checked everything. Everything is available. Your ODP is very good. He has done everything. Now, how will you proceed with the case? In the examination, we have just got a limited time of nearly 2.5 minutes to answer this question when they ask you, because they
Okay,
have
sir.
to ask you 5 questions. We
Okay,
can't say, we will say, you have to just summarize the things that I will prepare this. I will take care of just like you said, I will take care whether the machine is working, suctions are working, 2 suctions working, hypothermia, beer hugger is there, and fluid is there. This. Because they will stop you because they will not come to the actual answer at that time.
okay, sir.
Okay.
Okay.
So they will just, because once they give you the answer, because they've got 12.5 minutes for one
Mm.
viva, they will give you 10 minutes to prepare. And those 12.5 minutes, you have to answer this.
Okay, sir.
And they will have 5 questions to answer, 5 subsequent questions to ask you.
Okay,
Okay.
sir. Okay.
You are
Okay.
doing very good. Your management is exceptionally on the spot. That's not a problem. But I'm
Okay.
just telling you from the way of answering the question. That's it.
Yeah. Yes, sir.
Because,
Sure. I'll take.
okay. Okay.
Yes, sir. I
Now,
will keep note.
now, how will you proceed with the case?
Okay, sir.
Anesthesia.
Yeah. So, sir, I will make sure that there's a trained anesthetic technician with me, and I will take 2 wide-bore IV cannula and arterial line under local anesthesia, and I will connect the monitors. And I will plan for awake fiber optic intubation. I will inform the patient of the procedure, and I will avoid any sedative medications, but I will give injection glyco beforehand. And I will, in one nostril, I will insert a nasal catheter and give 100% O2. Keep the patient in the sitting position
Okay.
and connect the monitors. And I would go ahead with, in the waiting room itself, I will prepare the nose by keeping cotton plugs soaked with local anesthetic, 2% lignocaine and phenylephrine, sir. And in the OT table, I will spray 10% lignocaine on the posterior 1/3 of the tongue and the oropharynx. And then gently informing the patient, I will proceed with awake fiber optic intubation, sir. Preferably with a small sized armored endotracheal tube.
Okay. Good. Now, the thing is, in the anesthesia, there are no right or wrong answers. You can always, everybody has got their own way of approaching a particular patient or a particular disease for the anesthesia.
Okay,
So it's just more like a kitchen where you've got all the ingredients, and you are at the end of the day, your dish should be palatable. I always feel like that. What you are doing is very good. You can do it by awake fiber optic intubation as well.
Okay,
But
sir.
what I will say is, if you say that awake fiber optic intubation, you will say that I will go for the awake fiber optic intubation by preparing the patient beforehand. Then you say, do you want me to tell about the awake fiber optic intubation? In that way, what you will do is, you will, if they ask you awake fiber optic intubation, then you will have, awake fiber optic intubation, to describe it well. Then you
Yes.
will answer 2 questions in one question.
Okay, sir.
Got it? Got my point?
Yes,
Rather
yes, yes.
than describing yourself, let them ask you, how will you go ahead for the awake fiber optic intubation? You
Okay,
mentioned awake fiber optic intubation, let them ask you. If they don't stop you, keep on speaking. Okay.
okay.
Now you have done the awake fiber optic intubation. What are the risks and benefits of doing awake fiber optic intubation in this case? Benefits, I tell you, that you said the patient is, you suspect there is a narrowing and all those things. What are the risks involved in awake fiber optic intubation in this case?
So in this case, the risk involved is that sometimes there is a narrowing already of the airway, and while I'm doing fiber optic bronchoscope, I will also obstruct the existing airway.
Yes.
If I'm not, so that is a big concern over here. So I will always have a plan B for a tracheostomy, sir, after discussion with my consultant and the surgeon.
Okay. Fine. Now describe how will you do awake fiber optic intubation. You said whether you will give any sedation, or whether, what's your main stress on that? Whether you give transtracheital blocks, how will you go ahead with this?
No, so I will not give any sedation because these patients are highly sensitive to the sedative effect, and it can
Okay.
depress their respiratory system. So I will avoid any sort of sedation. But I will make sure I anesthetize the airway properly with local anesthetic spray or gargling, and then spray as you go technique. I will use that, sir.
Okay. Always remember, in awake fiber optic intubation, sedation is never a substitute for inappropriate local anesthetization. If your local anesthesia is good to the airway, you will need minimum of the sedation in most of the cases. Okay.
Yes.
Never complement, if your airway is not suitably prepared, you will need more sedation and you will end up in some problems sooner or later. Never substitute sedation for the good local anesthetic preparation. Okay.
Yes.
Very well done. Now, what are the other factors that need to be addressed with the patients having thyroid surgery? These you have, what else you will see?
For the mainly bleeding. So my other concern would be positioning of the patient, especially the eyes. I will pad them properly and I will tape them, and extension of the neck. I will make sure the head is slightly raised and extended and secured. And I will also make sure the hand is adducted. If the hand is adducted and my access becomes difficult, I will make sure I have insufficient extensions for my IV.
Okay.
And next is if the surgeon wants to test the integrity of the recurrent laryngeal nerve intraoperatively, I will make sure I withhold my dose of muscle relaxant, and I will use the neuromuscular monitoring to my benefit, sir.
Neuromuscular monitoring. Now, think with this patient, if the patient is having a large goiter, you are unsure about the bleeding. First is you have to carefully protect the eye.
Yes, sir.
Secondly, the eye should be prepared, taped, padded. Patients may have, because it's not always that patient will be hyperthyroid. Patient may be hyperthyroid. Patient may be having exophthalmos. So you will need to properly pad and take care of the eye.
Okay, sir.
Then, as you already mentioned, long IV access, because the hands will be ducted. The surgeons will be standing on the both the sides.
Yes, sir.
Neck will be extended. You should lift the head 25-degree head lift should be done so as to decrease the venous drainage,
Yes,
also
sir.
that the blood loss is less.
Yes, sir.
Okay. And now you have done the case, bleeding is controlled, everything is fine. Now,
Yes,
how
sir.
would you extubate this patient?
I will make sure the patient is hemodynamically stable and normothermic during extubation, and the patient has spontaneous breaths, taking good efforts, and I will make sure at that time whether the TOF is more than 0.9 TOF ratio, and then I will fully reverse the patient. Once a patient has adequate breathing such that the tidal volume is more than approximately 10 ml per kg, and there is good hand grip and head lift, I will, and the patient is awake and obeying commands, sir. And
Okay.
I will,
Yeah,
yeah,
please continue. Please
and
continue.
I will extubate the patient, making sure that I have making sure that I'm ready to re-intubate if needed.
Okay, fine. Now, coming on to the extubation, like that, good hand grip and head lift is there, and good hand grip is there. These are all clinical parameters to define the reversal of the neuromuscular function.
Yes,
And
sir.
but when we are answering in the exam, these are good thing to do in practice. I still do those things. That's not a problem. And when you have got neuromuscular monitoring, you should have TOF ratio more than 0.9, as you told. You should always tell that I will start with the TOF ratio. I will reverse. If the TOF ratio is less, I will reverse with the Sugama Dex if I have given rocuronium. You know what you have given. You will tell in the starting up at what you have induced the patient with.
Yes, sir.
And if not, then you will give the other. If it's more than 0.9, you can reverse with the neostimin and glycopyrrolate. Otherwise, you will reverse with the Sugama Dex, so that you don't want the patient to land up in any residual neuromuscular paralysis. Okay,
Yes, sir.
always say, because in this part of the world where I'm working and where you plan to come, it's all evidence based. They don't consider that much give importance to the clinical skills, like that you will say head lift is there, sustained hand grip is there, and a head lift for more than 5 seconds. That shows that there's a adequate neuromuscular power is there. But they will say, no, it's you have to always mention TOF, that we'll use the help of neuromuscular monitoring to test whether what to do, whether we have to give Sugama Dex or whether we have to give any other reversal agent. Because here in this part of the world, the trust I'm working, they only have rocuronium and
Okay,
scoling.
okay,
That's it. And nobody uses scoling. They always use rocuronium for all the patients. And they
okay, sir.
most of the times they use Sugama Dex, because they give rocuronium, they give Sugama Dex. That's it. So if the patient, if you have to see, because once the examiner tells you at the time of the introduction where they are from, if they are from the UK or from the European countries, then you have to go by that. You have to just keep that in mind, that you have to tell this thing if this question comes. I know it's too much, it's overwhelming at that point of time when you're already stressed to see from where the examiner is coming.
Okay, sir.
But always make it a plan, because we are giving an European exam, and so we have to answer them accordingly. Because what practice we do in India, we are clinically very good. I suppose all of you are very good clinically, and you can get all these cases done. But to tell them in the Viva is a altogether a different thing,
Okay,
because
sir.
they want to hear a certain particular things. Head lift, sustained head lift, these are very good markers, but these are surrogate markers. The objective measurement is the TOF ratio. Okay.
Okay, sir. Okay, sir.
Okay, fine. Now you have done the case. I'm sticking to the podcast. I will digress from this podcast later on. I'm sticking to the podcast at the moment. You
Okay,
are
sir.
called to the ward to see this patient 3 hours after the surgery.
Yes.
Yes, distress with oxygen saturation of 78%.
Okay.
How will you proceed? What are the immediate post-operative? This question can be asked in the different way. What are the immediate post-operative complications of thyroid surgery, and how will you manage?
Okay, sir. So once I am called, I will initially, once I come, I will connect 100% O2 to the patient first, and then I will make a quick assessment of the vitals, hemodynamic parameters, and the things which will come to my mind because of the respiratory distress are four things, sir. Either it is hematoma, which is compressing the airway, or it is the nerves has been injured and there is airway obstruction. Next, laryngeal edema can be a cause, or in case of a long standing goiter, it can also be tracheomalacia, sir.
Okay.
So these things will be coming to my mind. So when I will, yeah. Okay, sir.
Okay, so you have got the answer for the hematoma that the caregiver is that you will you take the patient to theatre and resolve it.
Yes.
What if the patient has got a tracheomalacia? What will you do in that case?
Sir, I will in that case, I will go for an immediate go for an immediate intubation, and I will make sure my consultant is informed, and also the ENT surgeon is also informed. But I will go for a immediate intubation of.
Okay, the immediate intubation, very well done. Immediate intubation you will do, and then you will proceed, will liaise with the ENT consultants to see for the need of the tracheostomy that is to be done.
Yes, sir.
Now, coming on to that sort of coming into the main point in the thyroid surgery, where the YY is definitely going to go, is recurrent laryngeal nerve palsy.
Okay.
Now, what are the consequences of damage to the recurrent laryngeal nerve? It's a very tricky question to answer because there are three things. One, you have always to see whether it's unilateral or bilateral,
or complete or partial,
or complete or partial. These are four
yes.
different things, and the four different things have got four different positions of the vocal cords, and your management will depend upon that. Okay.
Yes.
For the starting, let me tell you, recurrent laryngeal nerve supplies all the intrinsic muscles of the larynx except the cricothyroid. Okay.
Yes.
Fine.
Yes, sir. Okay, sir.
That's it. Now let's proceed with the what will you do with the what are the consequences of damage to the recurrent laryngeal nerve? Just tell by complete unilateral, complete bilateral, complete partial unilateral, and partial bilateral. Just tell like this.
Okay, sir. So first, if it is complete unilateral, then the side that is affected the vocal cord will be in the cadaveric position. So there will be, but the other vocal cord is functioning. So that will compensate for the strength of the voice, but there will be chances of a risk of aspiration and weakness of voice will be present. So
Okay.
this is this is the risk that is involved, sir. In case of bilateral complete, then both the cords will be in the cadaveric position, and the risk of aspiration is increased.
Voice will be soft.
Sorry, sir.
Voice will be soft.
Yes, voice also will be soft, sir. But otherwise, there will not be complete airway obstruction.
Okay.
So now coming to partial, coming to partial unilateral. So the affected cord will be in the midline.
Okay.
But the other cord will be functioning. So
yes, you're right. Go ahead.
yeah, the other cord will be functioning, but so there will be a lot of stridor, and we may need to intubate this patient, sir.
Okay.
And in case of bilateral partial, then both the cords will be in the completed overlap adductor portion. This is an emergency situation where we need to do a tracheostomy.
Okay. So the recurrent laryngeal nerves, very well done, Dr. Ishmael. The recurrent laryngeal nerves can be affected by three things, whether it's due to the compression, direct compression by the goiter, ischemia, or by the direct injury or the traction during the surgery.
Yes, sir.
Now, the partial injury is much more dangerous than the complete because in the partial, the abductors are more commonly affected than the adductors ones.
Yes, sir.
And the bilateral partial is the most dreadful scenario for an anesthetic because it will lead to the cords lying, both the cords lying in the midline and causing complete airway obstruction. Okay.
Yes, sir.
In that case, you have to manage the airway. Either you have to do the tracheostomy, or you have to do find how to you pass the tube, or you do anything.
Yes, sir.
Okay.
Yes.
Now coming on to now the next question is given like name other major postoperative complications. The major postoperative complications, there will be hypocalcemia that will be available after 36 hours because parathyroid is removed, and you have to see how will you check the hypocalcemia, Chopstick signs, and the Tossier signs that you can give calcium. That's okay. That will everybody of you know.
Okay,
Now
sir.
coming on to one major thing that the question, this is about the hypothyroidism and its anesthetic implications. Now
Okay,
the
sir.
next major thing is pregnancy and the hypothyroidism. You will
Okay.
get many questions. I tell you the patient, you just tell me how will you proceed with the case, because because most of the cesarean sections are being done on the spinal section under the spinal anesthetic only. So, but what considerations you will see before we'll just focus on the pre-operative evaluation in this patient.
Okay,
A
sir.
35-year-old female coming to you first time with no regular antenatal checkups has
Okay, sir.
come for the cesarean section. She is having a heart rate of 50, 60, 65, blood
Okay.
pressure of 110/70. She has got more weight gain than the usual weight gain in the pregnancy,
Okay.
and she is having preeclampsia as well, high blood pressure. Sorry, blood pressure is on the higher side, but she is having preeclampsia.
Okay, sir.
So she is having her TSH was normal in the first trimester, but over the period of time, then she gradually is not on any any altoxin medications. So how will
Okay,
you
sir.
proceed ahead with this case?
So this is emergency or if elective, sir?
Elective sections, because even if it's elective section, patient is having preeclampsia, it's a semi-elective or urgent, you have to do it. We can't wait for the pregnant patients to turn to you thyroid to do the surgery.
Okay, sir. Yes. So for this patient, I will evaluate all. I will take a detailed history, examination, and investigations for this patient. Regarding pregnancy, also I will assess the patient, the cardiovascular status because she is preeclamptic, and also the thyroid. For the thyroid, knowing that she is hypothyroid and uncontrolled, I would get the opinion of endocrinologist for pre-optimization of the patient, sir. And I will also focus on the airway assessment because already in pregnancy, the airway becomes a difficult airway because of oral edema of the soft tissues. And along with this, the patient may also have a large tongue because of the hypothyroidism. And and I will check for any hoarseness, that is symptoms and signs and symptoms of hypothyroidism and airway compromise. And if there are changes in the voice, I will document it. I will document all my findings. Coming to investigations, I will take a complete blood count, the HB platelets. I would also want to do a clotting coagulation profile for this patient, and LFT in addition, and a thyroid function test also, and cross match blood grouping and typing for cross matching, and also see the urine serum creatinine and also the electrolytes, sir. I will take an ECG to check for, since you said she has bradycardia, so I will check for the rate. 12 lead ECG I will take, and also to see for any conduction defects.
Okay,
Yes, sir.
good. Why now in pregnant patients in the first trimester, due to the pregnancy hormones, the there is a subclinical hyperthyroidism most commonly found in the first trimester in the most of the pregnant patients.
Yes, sir.
In the iodine deficient areas, it's nearly about 20%. In the iodine replete areas, it's less than 20%. So every pregnant patient, you should always be worried about whether to check the thyroid status before you take the patient for the anesthesia.
Okay, sir.
The reasons for that are because the things are confounding. One, the airway is already difficult.
Yes.
Secondly, the patient's tongue is large. Third, patient may have weight gain that may be confounded by the more weight gain in the pregnancy as such.
Yes,
so you
sir.
are not able to distinguish itself that whether this symptom is due to hypothyroidism or due to the pregnancy itself. So you should always have a high index of suspicion and be always careful without when you are anesthetizing or giving spinal to a lady with a hypothyroid lady.
Yes, sir.
Secondly, while giving regional anesthesia itself, one, you should always check the coagulation.
Yes.
Secondly, the weight gain will be excessive. You will have more. And thirdly, the patient has got preeclampsia. There will always be a more weight gain, and your regional anesthesia will itself be difficult rather than a normal patient.
Yes, sir.
Their baroreceptor reflexes are already blunted. The response to phenylephrine in hypothyroid patients is blunted. It's not that great as it to the metformin.
Yes,
okay,
sir.
so always take care that phenylephrine, in this part of the world, phenylephrine is a drug of choice. So they give phenylephrine infusions for cesarean sections in start.
Okay,
They don't use like mefentramin sulfate that we use back home in India.
Okay.
Okay, they use always phenylephrine infusions. Few people use other ephedrine also, ephedrine and metforminol, but phenylephrine is the drug that you use most commonly. So when you are asked how will you manage the hypotension in this such case or any case, you will always start in pregnancy where we will use phenylephrine infusion. Okay, these are not related to this topic, but I'm telling you that these things they will need to listen. They want to listen these things. When I gave the exam, I was not knowing that they want to listen these things.
Okay, sir.
I just gave them the answers that I practiced all my life.
Okay, sir.
Okay.
Yes, sir. Yes, sir.
Okay. Now, subclinical hypothyroidism is very common in the patients who are pregnant. So I also told you always be prepared for the hypothyroid patients, difficult airway, difficult spinal, and one thing more, these patients are more prone to the anxiety attacks and postpartum psychosis as well. Okay.
Okay, sir.
Okay, so these are the major things about the hypothyroid. Now this is not a topic in this one, but I tell you that what more it can be asked when you're asking for the lead up follow-up questions for the hypothyroid are. One is mixed edema coma. How will you treat the mixed edema coma? If the patient, you have any surgery you have got done and the patient goes to the ward and the patient gets into the mixed edema coma, patient feels sick, you should go check the investigations, see the patient, if the patient is having hypothyroid. Secondly, if any patients, any general anesthesia you are giving to the patient, these hypothyroid patients may have some adrenocortical insufficiency as well. So you may need to give the patient hydrocortisone also along with the thyroid, along with the regular thyroid medication that we're giving.
Yes.
For the mixed edema coma, you can see, you can read the sign and symptoms of the mixed edema coma. That may be topic of the critical, that may be asked you in the critical care by itself or anywhere here itself. It can be lead up questions. It will never be the first question of the mixed edema coma in the practical setup, in the clinical setup. The levothyroxine, you should know the what's for the T4, the half life is 7 days. For the T3, it's 1.5 5 days. So it's you have to give like different drugs.
Okay.
So these are the questions that you may be asked on hypothyroidism. Anything else? Good afternoon, Dr. Shiv. Anything you want to add, please? Hello? Dr. Shiv, good afternoon.
Hello, Aman.
We are mostly done with the hypothyroidism now. Anything you want to add, sir, please?
Sorry, I don't know what was going on, so I don't know what's. I just joined.
No, it was a class about the hypothyroidism and its anesthetic complications. So we have covered most of the part. We are just about to wind up now.
Good. Well done.
Okay, thank you so much, sir. Okay, anybody has any questions, please?
Sir, I just want to know, like, where are the areas which I can improve here now more?
Your management is very good. You told everything very systematically, but you should answer only what it is asked of you. You shouldn't answer the next question, that next lead up question that the examiner may ask you.
Okay, sir.
That's it.
Okay, sir.
And always be stepwise. From pre-operative evaluation, if you're start from the history, physical examination, investigations, and always tell why I will do this investigation. If you're asking for thyroid function test, you should tell why I'm getting the thyroid function test done. If you're asking for the ECG, why should I get the thyroid ECG in this patient? Always tell this one. That's it.
Okay. Yes. So one more question I have is that these hypothyroid patients, they have delayed gastric emptying, sir. So do we have to take, will we always consider them as full stomach, or like we'll have that NPO criteria for them also? So one doubt I just.
It's normal NPO criteria for the hypothyroid patients, but you should always consider that they may have more increased risk of aspiration than the normal patients.
Okay, sir.
There is no particular different NPO criteria for the hypothyroid patients.
Yes, sir. So like, do we have to do an RSI for these patients? Not necessary.
It depends upon the surgery that you are doing. If you are doing a laparotomy, emergency laparotomy with intestinal obstruction or something like that, you have to do RSI. But if you're doing a routine surgery with adequate fasting, then I don't think you need to do any RSI. Because in these patients, if you do RSI, your airway is you are doing incoital surgery, it's very difficult. The airway is already compromised. You are making much more difficult for the anesthetist to intubate the patient.
Yes, sir. Okay.
Okay, with this one, so what we have done is hypothyroid and its anesthetic complications. It's my one request to all of you that I will be sharing a feedback form in the Gyan group that it will just take you 2 minutes to fill that feedback form. It will help us in improving ourselves also, that where we are lacking, how we can improve the more teaching and what more topics you want to be taught. So we can incorporate that in the next coming lecture itself. And it will be for all. I will suggest to give feedback for all of the lectures, not even by me, but for everyone. Okay. Thank you so much.
Thank you so much, sir.
Okay. Thank you so much, Dr. Indumani, for coming here. Thank you so much. Thank you, all of you.
Dr. Prashant here, so I can end the stream?
Yes, sir. Yes, please.
Yeah, thanks.
Thank you so much.